I had the pleasure to give a talk here at BSH about the management of high-risk myeloma and the definition of high-risk myeloma. So myeloma, we know, has seen a lot of improvement in outcomes over the past years. Luckily, we have new drugs, and this is really filtering through in the real world. We see more and more patients that have a well-controlled disease over many years. But one has to say, unfortunately, the disease is a disease that is remitting, relapsing, and it does come back in our patients. But there is a subgroup of patients where that happens pretty quickly, and that's the type of myeloma that we call high-risk myeloma. There is actually different ways how you can define that group, and some patients just have factors that they come with from their background. Either their kidney function isn't as well, or they have other frailty measures that just doesn't let them tolerate treatment, and that can lead, of course, to treatment failure in the end of the day. But what I was really focusing on was the so-called molecular high-risk population, so where the disease biology is driving the disease behavior, where the disease has genetic aberrations that make the disease grow faster, proliferate faster, and that way, despite standard of care treatment, the disease comes back quickly. So we have ways now of genetically analyzing these cells, of identifying both genetic aberrations, which in myeloma are mostly copy number changes and large-scale translocations, or features that we can identify by gene expression profiling, and there are standardized ways now of doing that with which we can identify these patients up front. And it's very important that we learn that up front when the patient is diagnosed, because once the disease has come back for the first time, unfortunately we cannot achieve that good a response anymore. So the earlier we know what we're dealing with, the earlier we can adapt treatment. And that has led to a very exciting study, which we're very grateful for having it open in the UK. It's the so-called Myeloma UK 9 study, also called OPTIMUM, which actually offers up to 620 patients in the UK such molecular profiling, which they could otherwise not get on the NHS. And for the ones that are identified to have genetic markers that makes the disease biology more aggressive than in others, we can also offer these patients enrollment into a trial that gives them treatment that they could otherwise not access in the UK. Now, of course, we want to learn whether this treatment is doing better than standard of care treatment, and we will compare this against another trial where we analyze patients the same way. And if we find that it is working better, we hope that this can help as well improving access across the board, not only for trial patients, to such more intensive but also more effective treatment, hopefully.